Hello everyone, today we'll be discussing a case presentation. This case presentation focuses on Mr. AD, a 60-year-old male who experienced an anterior ST elevation myocardial infarction that was complicated by post-angiographic complications and subsequent management that involved insertion of an implantable cardioverter defibrillator, or ICD. The case highlights the clinical challenges and interventions that are required in managing acute coronary events as well as their complications. Patient admission overview. Name Mr. AD, 60-year-old male. So it's important to keep the dates in mind so that we look at the subsequent presentation of the patient. So date of admission was 12 July 2025, came in at 11:34 a.m. And he was initially discharged on July 14, 2025 at 10:02 a.m. This timeline sets the stage for understanding the progression of his condition as well as the interventions that were applied during his hospital stay. Clinical findings and diagnosis. Mr. AD has a significant past medical history that included heavy smoking as well as ischemic heart disease that was diagnosed in 2010. On examination, cardiovascular sounds were normal, but in the respiratory system, wheezing was noted. ECG was done that showed ST elevation in the anterior wall, anterior chest slits, as well as echocardiography that revealed reduced ejection fraction about 35 to 40% with an akinetic anterior wall, confirming the diagnosis of anterior ST elevation MI. These findings emphasize the severity of myocardial injury and compromised cardiac function. Cardiac biomarkers on admission were markedly elevated, with troponin I being 12.36, while normal should be between 0 to 0.028, myoglobin being 228, while normal should be 0 to 72, and CKMB being 30.19 when normal is between 0 to 4.8. These elevated markers confirmed acute myocardial injury and helped guide the urgency and intensity of the treatment. Post-angiographic progress. Patient underwent angiography on the same day that he was admitted, that was on the 12th. The following day, patient remained asymptomatic with stable vital signs, including blood pressure, heart rate, temperature, and oxygen saturations. The management plan focused on continuing prescribed medications, routine monitoring, and continued cardiology evaluation. This period was critical for observing any post-angiographic complications and ensuring stability. Initial discharge. So this following day, so that is day 2 post-admission, Mr. Eddy was prescribed a comprehensive medication regimen that includes dapagliflozin, sacubitril valsartan, aspirin, ticagrelor, furosemide, eplerenone, bisoprolol, and aldanil, which is rosuvastatin. So these medications mainly target the heart failure management, antiplatelet therapy, and blood pressure control, reflecting a multifaceted approach to secondary prevention and cardiac support. Then of note is later on July 14, the patient returned to the emergency department with shortness of breath and headache after meal. Vital signs showed a tachycardia and mild hypoxia. ECG was done that confirmed ventricular tachycardia, a serious arrhythmia. Immediate interventions included IV amiodarone, electrical cardioversion under sedation, leading to successful restoration of sinus rhythm. Thereafter, patient was admitted to ICU for close monitoring and further management. So when we take note, these were the vitals. So the blood pressure was 131/54, the heart rate was 117, and the saturations were 96%. But he was still complaining of having breathing difficulties. Then they did a repeat of the cardiac markers. Of note, the myoglobin, kmb troponin I was still elevated. However, that was as a result of the previous injury that we already knew about. ICU management summary. So, day 1 post-readmission in the ICU on July 15, the patient received amiodarone infusion and noradrenaline to maintain adequate blood pressure. Hemodynamics stabilized, but the ejection fraction was noted to be further reduced to 30 to 35%. The initial coronary angiography findings that revealed total occlusion of the left anterior descending artery and subtotal occlusion of the right coronary artery. Due to the above, the cardiothoracic surgery team was consulted and plans were made for ICD insertion to prevent sudden cardiac death. Then a multidisciplinary joint review was done the same day, later in the day. Attending physician and the nursing team reviewed the patient. He was found to be awake, alert, and stable. Preparations for pacemaker insertion included discontinuing Clexane, which is enoxaparin, 12 hours prior to the procedure, continuous heart rate monitoring with a threshold of 100 beats per minute, and early morning electrolyte checks. On the 24th July, pacemaker insertion was done. The patient was closely monitored in the medical ICU with continuous telemetry and hourly blood pressure checks. Post-operative care included IV paracetamol for pain management, regular wound inspections, and vital signs monitoring. ECG and chest X-rays were performed to confirm device placement and rule out complications. Discharge was planned based on clinical stability, with follow-up wound review and device interrogation as scheduled. Then the final discharge summary included antiplatelet medication, heart failure drugs, and antibiotics for prevention of infection. Scheduled follow-up included an initial review on July 29 and ICD device check programming after 6 weeks. This comprehensive plan ensures ongoing management and optimization of cardiac function post-discharge. So, case summary. In summary, Mr. AD presented with an acute anterior ST elevation MI that was complicated by ventricular tachycardia. Initial treatment with amiodarone and cardioversion stabilized the rhythm. Coronary imaging showed severe occlusions that required ICU care and pacemaker implantation. He was later on discharged in a stable condition on a tailored medical regimen with planned follow-up for the ICD management, highlighting a successful multidisciplinary approach to a complex cardiac case. That's all. If you like the video, please like, subscribe, and comment. Thank you.